Welcome all to the class. So today we will discuss the TOG article from the Maternal Medicine module, that is Haemoglobinopathy consideration for reproductive health. Okay, so this is the hemoglobinopathy and the reproductive health. Now, when we discuss the reproductive health, that will include mostly the patients who are desiring to go ahead with the pregnancy, and these patients are having the hemoglobinopathy. What is the protocol that we are going to discuss? So before going into the detail, let's see the types of hemoglobinopathies. Two things we have already discussed in our lectures. One is a beta thalassemia, second is a sickle cell disease. Okay, same thing here. It is a sickle cell disease, which is a homozygous condition. Okay, so homozygous beta globin mutation is there. You have hemoglobin HB, it is denoted as a HbSS. Okay, so these patients require intermittent transfusion, and iron load will depending upon the frequency of transfusion, there will be iron overload. Okay, then we have another condition, that is a heterozygous condition, HbSC. Here these patients, it is a heterozygous condition. uh, from one parent there is a hemoglobin S gene is coming, from other parent it is a HbC gene is there. So it is a combination of HbS plus HbC. So these patients require a occasional transfusion. So iron overload risk is relatively less. Okay. Now, if you see the beta thalassemia major, there is a severe beta globin defect, and these patients require a lifelong transfusion, and maximum risk for the iron overload is present in this beta thalassemia major. So we have also seen the comparison between the sickle cell and the beta thalassemia. Okay, in previous discussions, if you remember. So beta thalassemia major will have the regular lifelong transfusion. That is why the iron overload risk is maximum. Next is a beta thalassemia intermedia. These patients will have mild to moderate defect. They also require occasional transfusion. Okay, and iron overload risk is minimal. There is increased GI absorption plus transfusion. So it is mainly because of two things, uh, iron overload which happens because of the increased absorption and because of the transfusion, but maximum with the beta thalassemia major. Third is HbH disease. HbH disease is alpha thalassemia. Okay, there are three alpha gene deletion. So this also require occasional transfusion. So iron overload risk is there, but less common as compared to beta thalassemia. Then we have HbS beta thalassemia. Now this is also a heterozygous condition. Okay, you have HbS also, you have beta thalassemia also. So there is a sickling plus thalassemia mutation. Again, transfusion requirement is a variable. Okay, so iron overload is there, but not like a beta thalassemia major. Last one is a HbE beta thalassemia. Here also it is a heterozygous condition. That means there is a HbE plus there is a thal mutation. The transfusion requirement is a variable here. Again, here the iron overload risk is there, but it will be less than the beta thalassemia major. So if you see this, so whatever is given to you, just see whether it is a homozygous condition or whether it is a heterozygous condition. If it is a homozygous and having beta thalassemia, that will be the maximum risk, while sickle cell homozygous will require intermittent. So the risk will still be, it will depend upon the number of transfusions, but regular and lifelong transfusion will be definitely required for beta thalassemia. While sickle cell patients, they will require in acute condition where there is a acute stroke or acute crisis and all. Okay, so not like the beta thalassemia major. Okay, now coming to the pathophysiology of the iron overload. So main with these all hemoglobinopathy, what we have seen central is a iron overload. Okay, now with this iron overload, this mainly because of two things. One is because of the repeated transfusion that will give 200 to 250 milligrams of iron per unit. Suppose if you are giving the two transfusion in a month to beta thalassemia major patient, that means you are giving 500 milligrams of iron to the that particular patient in a month. So over a period of 12 months, how much you are giving? Almost 6 grams of iron, which we are going to give to that patient in a year. Okay. Not only that, there is increased absorption because these patients have a reduced levels of hepcidin. Now, this hepcidin is responsible for the control of the iron absorption. Just for the practical point of view, we remember when the hepcidin levels reduce, the absorption of the iron increases. Okay, this you remember just. Okay, there is no, and another important thing about iron is there is no physiological active excretion of the iron. So it leads to the accumulation. Whatever the iron is lost from the body, that is lost because of the shedding of the cells. There is no active secretion outside the body. That is one more important thing. So what happens in this patient? There is a repeated transfusion from their iron is coming. Not only that, there are decreased levels of hepcidin, so it is getting absorbed more. And third, there is no excretion, which is there in all patients, all human beings. Okay, so these factors are responsible for the iron overload. So hepcidin controls the iron by blocking ferroportin. That is, high hepcidin lowers iron, and low hepcidin increases the iron. So iron overload leads to the excess iron input, which is mainly because of the transfusion plus increased absorption due to decrease in levels of hepcidin, and there is no excretion. That leads to the toxic accumulation of the iron into the various organs. So toxic form is a non-transferrin bond form that produces oxidative stress. Okay. Now, organ damage due to the iron overload. So key organs which are damaged, one is a heart, where there is a cardiomyopathy and there are arrhythmias. In liver, it leads to the fibrosis and cirrhosis, and there is endocrinopathy. Okay, this endocrinopathy is one of the important thing as far as the reproductive age group is concerned. Okay, so what happens? What are the endocrine effects? So in males, it will lead to the delayed puberty. In also, it will lead to the hypogonadism, abnormal semen, decreased semen motility, and erectile dysfunction. These are the affection in male because of this endocrinopathy. While in females, it will lead to the delayed puberty, hypogonadotropic hypogonadism, oligomenorrhea, amenorrhea, anovulation, ovarian insufficiency. Not only that, the even within the endometrium cells, there will be accumulation of this iron deposition. Okay, so what is the mechanism of this endocrinopathy? The iron deposition happens in the pituitary also. Okay, and that is the earliest change which is noticed. That will reduce the decreased GnRH response. So there is a decrease in FSH and LH, and that will lead to the hypogonadotropic hypogonadism. So this concept you remember how these patients have reproductive issues, and this is one of the concept which is tested not only part 2 but also in part 3 also. Okay, so that leads to the reactive oxidative stress that will lead to the damage in form of folliculogenesis will be hampered, oocyte quality will be hampered, implantation is affected. So that is how this reactive oxidative stress is going to create a problem. Then coming to the female fertility, there is a pituitary function dysfunction that will lead to the anovulation. There is a ovarian damage, so ovarian reserve is reduced. Then endometrial iron deposition is there, so implantation will be affected. So overall, if you see, there is a hypogonadotropic hypogonadism almost in half to two-thirds of cases. In cases of thalassemia major, 53 to 76% of patients, means 1.5 to two-thirds of cases of thalassemia major will be hypogonadotropic hypogonadism. Okay, so you can do the AMH testing. That is a useful marker. It has got an inverse relation with the ferritin. Okay. So as the ferritin levels increase, the AMH level will be reduced. So key factor for ovarian reserve will be AMH. Then for male fertility, what you see is a hypogonadism. Okay, mainly in sickle cell disease, you get around 25% of patients. 1 in 4 patients will have hypogonadism, while thalassemia, 3/4 of patients will be having the hypogonadism. Okay, this is mainly because of the difference in the iron overload in sickle cell and thalassemia. Okay. So what are the effects? It will lead to the oligospermia, azoospermia. There is a decreased motility. Then DNA damage is there. Erectile dysfunction can happen. Priapism can be there in sickle cell disease. Okay. Now we need to go for assessment of fertility in these patients. Okay. So for female, the baseline tests are recommended at AMH level, then FSH, LH, estradiol, and what you do is antral follicular count. There is no specific test for hemoglobinopathy patients. So only for hemoglobinopathy as such, there is no test. Whatever test we are doing routinely, those tests, that is AMH, FSH, LH, estradiol, and antral follicular count, we are going to do. For male, semen analysis is the first line. There should be abstinence for 2 to 5 days. Repeat after 3 months if it is abnormal, and hormonal profile if we need it. Okay. Then monitoring for the iron overload. We need to monitor serum ferritin, that is widely used. Okay, but better than that, marker for the iron overload will be MRI. Okay, T2 MRI. That is the best and non-invasive. Okay, you can go for Feriscan MRI. That is an alternative. Liver biopsy is it was supposed to be the gold standard, but not used nowadays because MRI T2 MRI is available, which is a non-invasive. Okay, while liver biopsy will be little invasive. Then when there is an iron overload, these patients will require a chelation to prevent the overload of the iron. So what is the indication? When should we start the chelation? Around 10 to after 10 to 20 transfusion, the chelation is indicated. Or if the serum ferritin is more than 1000 microgram per liter, chelation therapy is indicated. So remember indications of the chelation therapy. If the ferritin level more than 1000 or after 10 to 20 transfusion, go for chelation therapy. There are three drugs which are available for chelation. One is a desferrioxamine, second is deferriprone, and third is deferrosirox. Okay, so out of which desferrioxamine, that is given as a subcutaneous infusion, while deferriprone and deferrosirox, they are given orally. Okay, again, they are not indicated in pregnancy. So chelation is to be avoided in pregnancy, except only desferrioxamine can be used after 20 weeks. Okay, that too in a selected cases. So coming to the management of infertility. So first line will be early and optimal chelation. So before they consider the pregnancy, see to it that they chelation is already achieved. Okay, and then you have to stop the chelation before conception. First, optimize the iron overload of these patients by going for the chelation. Okay, then hypogonadotropic hypogonadism will require stimulation with the help of HMG. So only oral stimulation like clomiphene or letrozole may not be sufficient. So these patients will be requiring gonadotropins. So that will be required for ovulation or spermatogenesis. Okay. Other option will be ovulation. ART options will be ovulation induction and IVF. Okay. If it fails, then go for egg donation, sperm donation, or embryo donation. Then cryopreservation in females, oocyte cryopreservation, embryo cryopreservation, or ovarian tissue. Okay, but that is not the standard care. First, you will go for decrease in the iron overload by chelation, and for then you go for stimulation with the help of gonadotropics. Okay. For males, it is the sperm can be considered for cryopreservation, considered before hydroxycarbamide therapy. Okay. Long-term consideration, there can be estrogen deficiency that will lead to osteoporosis, then cardiovascular diseases, dementia. So HRT is recommended for these patients. Okay, because it is like a condition like a premature ovarian failure. Then there are pregnancy-related condition. It is going to be a high-risk pregnancy. There is increased maternal fetal morbidity. So preconception, always optimize ferritin, stop chelation, then genetic counseling. Because these are the autosomal recessive diseases which are we are dealing with. So we need to discuss the risk of transmission also. Then from examination point of view, we should consider most common cause of infertility will be hypogonadotropic hypogonadism. Earliest endocrine organ affected is a pituitary. Best ovarian reserve marker is a AMH. Best non-invasive iron assessment is by MRI T2. Then main preventive strategy is the early chelation, and definitive fertility treatment is a gonadotropin. Okay, so that finishes this small talk article on reproductive hemoglobinopathy and reproductive options. Okay, thank you. We have few SBS, doctor. Can you please go ahead with SBA?
Yes, sir. A 24-year-old woman with beta thalassemia major presents with primary amenorrhea. Investigations reveal low FSH and LH levels. What is most likely mechanism of her condition? A. Direct ovarian follicular destruction. B. Iron deposition in pituitary gland. C. Endometrial fibrosis. D. Tubal blockage due to hemosiderin. And E. Autoimmune ovarian failure. It is B. Iron deposition in pituitary gland.
Correct. Next. So earliest endocrine damage lead to the pituitary. There is decrease in FSH and LH levels, and a hypogonadotropic hypogonadism is there. Next.
A 29-year-old woman with transfusion dependent thalassemia is being evaluated for fertility. What is the single most appropriate marker of ovarian reserve? A. Serum FSH, B. Serum LH, C. AMH, D. Estradiol, E. Inhibin B. It is C. AMH.
Yeah. So that is the best marker for ovarian reserve and inversely related to ferritin levels. Next.
A 32-year-old woman with sickle cell disease on regular transfusion is being assessed for the iron overload. What is the best non-invasive method to quantify iron overload? A. Serum ferritin, B. Liver biopsy, C. MRI T2, D. Serum iron, E. Transferrin saturation. The C. MRI T2.
Yes, that is the non-invasive test. Okay, MRIT2 is the most accurate non-invasive test. Okay, you should also remember the levels. Okay, last time we have
Yes.
discussed. Yeah, go ahead.
A 30-year-old man with beta thalassemia major presents with infertility. Semen analysis shows oligospermia. What is most likely contributing factor? A. Reduced testosterone due to adrenal failure. B. Increased seminal iron causing oxidative damage. C. Pituitary adenoma. D. Autoimmune orchitis. E. Varicocele. It is B. Increased seminal iron causing oxidative damage.
Yes. So increased seminal iron causing oxidative damage. Increased iron leads to reactive oxidative stress, leading to sperm DNA damage, leading to decreased motility and count. Next.
A 27-year-old woman with thalassemia major and hypogonadotropic hypogonadism wishes to conceive. What is the most appropriate initial treatment? A. Clomiphene citrate, B. GnRH analogs, C. HMG, D. IVF directly, E. Estrogen replacement. It is C. HMG,
Yes,
gonadotropins.
gonadotropin, they are required here. Okay. So induces ovulation, hypogonadism, and first line therapy. Okay.
A
Next.
25-year-old woman with thalassemia major is planning pregnancy. She is on iron chelation therapy. What is the most appropriate advice? Continue chelation throughout pregnancy, stop chelation during pregnancy. C. Increase the dose during pregnancy. D. Switch to oral chelation. E. Stop only in third trimester. To stop chelation before pregnancy, before conceiving actually. B is the closest option.
Mm, Continue. Throughout is not appropriate. Stop stimulation during pregnancy. Ideally, during pregnancy, we have to stop and consider in the second and third. Okay. It is a
Third
consider
time.
in the second and third. Okay. Then increase dose during not recommended. Switch to oral chelation. Stop only in oral chelation again because only desperate oxamine is recommended, which
Only
is given
subcutaneous is recommended.
subcutaneously. Okay,
Yes.
switch to oral chelation, not stop only in the third trimester, again not appropriate. Okay,
B is
so
most.
most operation appropriate is a B. Okay, so there is a potential teratogenicity. Exception is a desperate examined after 20 weeks in selected cases. Okay, next.
A 22-year-old woman with transfusion-dependent hemoglobinopathy presents with delayed puberty. What is the most common reproductive endocrine complication? E. Hypergonadotropic hypogonadism. B. Hypogonadotropic hypogonadism. C. PCOS syndrome. D. Premature menopause. E. Hyperprolactinemia. This B. Hypogonadotropic hypogonadism.
Yes, hypogonadotropic hypogonadism. Okay, most common endocrine complication due to pituitary iron deposition. So that finishes this talk article and it's SBA. Thank you, Dr.